So this is case of the day. Today is Wednesday and we have the 134th case titled Epiphyseal Involvement and the Skip Lesion. This 15-year-old had pain in the left distal thigh with mild swelling. I don't have the x-rays and you can see this is post-biopsy. But this is an aggressive bone-forming lesion. These are mean reconstructions from the CT that was done as part of a PET CT. And these show a typical bone forming lesion. There's periosteal reaction. This is an osteosarcoma. The MR was done, which showed the bone forming lesion. You can see the Sharpie's fibers here and the sunburst appearance. Again, very characteristic osteosarcoma. And if you remember, about 3 months ago, I did this piece called the sunburst appearance. This is only for those who find all this extremely interesting and intriguing, because I kind of went down a bit of a rabbit hole in this. So anyway, biopsy confirmed OGS, patient was referred for a PET CT. But before we go there, what is the role of MR? Apart from the fact that you would use it for diagnosis, given that the MR was highly suggestive of a bone tumor, you would also stage it at the same time. And there are these 5 things to look at. Extent is measuring the lesion and its extent from the articular surface, and in most cases the orthopedic oncosurgeons will do it themselves, but it's a good idea to get used to this. It takes 30 seconds to give these measurements. The other is neurovascular bundle involvement. Here, of course, the tumor is nowhere near the neurovascular bundle. But just in case you're interested in this subject, there was a lovely article from Delhi. This is a 3 center collaboration. So I think Safdarjung and Vardhaman and something else, Holy Family, if I remember correctly, and it was in skeletal radiology a few months ago. Um, there's no joint involvement as well. So we're basically now coming to 2 things: transphyseal spread and involvement of the epiphysis, and skip lesion. Again, very recently there was a paper that talks about the different signs that you can look at to identify epiphyseal spread. And one is direct visualization, the other is foci of altered signal intensity, so low on T1, bright on T2 or stir, edema, and discontinuity of growth plate. So edema perhaps is the least specific, because you can get edema even without tumor spread, but direct visualization, discontinuity, and this altered focal signal makes sense. So here, this was missed in the original report, because they just didn't look for it. I mean, if you don't know that you're supposed to, then you don't. But you can clearly see here that the tumor has gone past the physeal plate into the epiphysis. It's seen on the axial. The STIR, which was a larger field of view study, shows edema, but it didn't really show the tumor. So there is transphyseal spread. Now, why is this important? Because it may then preclude joint preservation surgery, and it is associated with poorer prognosis. So again, this is still not been published. It's an online first article in September where they looked at what happens to these patients, and they found that there is reduced survival and there is an increased incidence of pulmonary metastases in all of the patients who have transphyseal tumor extension. Now you need further imaging. So you need a whole bone T1 for skip meds, and you need a PET CT or a lung CT for lung meds and other metachronous synchronous lesions. Now they had done a whole bone T1 and a stir whole bone, which showed this focal lesion in the proximal femur. Again, worrisome for skip meds. And a whole bone T1 is good enough. So there were these 2 papers 5 years ago by Saifuddin and Barnett, again both in skeletal radiology, that showed that about 6.5% of high-grade sarcomas, this was inclusive of Ewing's and osteosarcoma, have skip meds in the same bone, and very rarely do you get skip meds in the opposite bone or elsewhere. So you really just need this one sequence for the as a whole bone. And MR is very, very accurate for this. Now, why are skip mets important? Because again, poorer prognosis, higher chance of recurrence. Uh, in any case, we have to do a PET-CT. So since the patient came to us for a PET-CT, the MR was done elsewhere, the lung was normal, and I had the opportunity therefore to then look for or reconfirm both of these things. And you can see here that the skip met is confirmed. There is a focal nodule in the marrow corresponding to the lesion on the MR that shows mild uptake. And the epiphyseal involvement is confirmed because we see frank osteoid in the epiphysis here. So both those things are confirmed on a second modality, and you don't really need to biopsy any of these to reconfirm the transphyseal spread and the skip metastasis. So when reporting MRIs of patients with suspected bone tumors, it is important to stage at the same time. And so while we look at the extent and measurements and joint involvement and neurovascular bundles, the other two things we have to look for are transphyseal spread, and specifically look for it, and skip metastasis, for which a whole bone T1 suffices in most instances. Rat Protect, all 2 months or maybe 1 month and 3 weeks from now, my WhatsApp channel. Thank you so much for viewing this.